PSA derivatives, and we actually talked about one of them, azolpidine. Azolpidine, we did talk about under RA. So this is an inflammatory disease, so many of the drugs we use for inflammation before are actually used in this. So Kathy has been asking for pictures. Brad helped me get them loaded up to the cloud so that I can get them down again. And so I am sorry, I feel like this is that terrible time when you're trapped and you have to watch somebody's vacation picture.
She's so funny.
I think there's only like 30 slides.
We saw the start, we want to know.
Okay, so I asked Dr. Britton if he wanted to come down because he'll always have comments. So.
One story about Schultz. I introduced this dog to my mother for the first time, and Schultz is he's afraid of people. He was going to be a therapy dog, but I rejected him because he lunges when he sees a new person, it scares him. And so he'll sit back and kind of watch, and he takes 2 or 3 visits before he actually knows him roll up and another pet. So I put him in the back of the F-150 and drove up. He was in the back of the window, rolled down. I told my mother, I said, you come out and then you can look at him. I said, you just look at him and you talk to him, but you can't really pet him. So she came out there and he's up there looking, and he's just sniffing and looking and everything. And then she tried to reach out and he went, I mean, he didn't bite her, but that's his first reaction. I mean, he did it to our daughter-in-law. Hackled up and kind of came at her and said, it's okay, Anna Claire, it's really going to be okay. Well, now, when she comes over, he jumps up on the couch and leans on her and just a baby. So I told my mother, I said, it's not you at all. I said, but he's a really sweet dog, trust me. He really is.
So here's the outside. You can see Dr. Britton looking up there. So we lived in Texas for about 5 years, and we really like Texas Hill Countries, and it fits the lot where we are. So that's kind of the type. So Texas Hill Country's houses are built over like 100 years, and they just kind of add on as they need. So they're really eclectic houses. There'll be a period, like they may have had stones at one time, then they add wood, and so it's very different. So that's kind of why it's like it is. That's our garage. We're trying to figure out what to stain the lighter colors. There's a little courtyard outside this is a bedroom in here, and this is by the front door. You can jump in whatever you want. This is looking up at the tower. It's kind of dark, but you can see the corbels. Really nice, very common. This is the stone is very much what you'd see in Texas Hill Country, and it's from Texas.
It's from Austin, Texas.
So,
it's called lunar stone, so you'll see that a lot.
Do you feel at home, Travis, when you look at it?
A little bit.
Let's see. This is inside the tower looking up. It's a 2-story tower. We thought about having antler horn chandelier, but we've kind of gone back to a black iron instead. When you're coming out of that front hall, you go through these doors into the living room, so it's kind of meant to keep the weather out. This, I didn't have a more recent picture. This has been all more painted and stuff, but this is the fireplace. And we have these nice beams in the ceiling. And there's a better picture of them. They're really pretty. Where'd they come from? They're old.
They're either from Iowa or New England. There's a company that tears down barns, and they took a lot of these old construction barns that really aren't nailed together, but kind of tongue and groove and have it all together. So they tear them down and they package them and they ship them to builders. So that's how we got them. So I don't know where they came from. They're definitely not from Texas.
You can see them here in the dining room and then also in the living room. So this is looking from the fireplace down. The windows have still got this blue wrap on it, so it tends to make it kind of a bluish cast. But the walls and the beams are reminiscent of the Hill Country. And then we like color. And because in the Hispanic population, they really like pops of color. That's why we have in our island and in this built-in, these are turquoise. They're kind of muted here, but they're real pretty color. That just gives you another one. This is where the wine fridge is going to go.
That's mine.
The ceiling here is barreled, so it's really nice, and then the beams kind of set it off. There's the beams, there's the barrel ceiling. There's the china punch cabinet. The wood is alder. It's really pretty. It's a knotty alder, so all the knots and kind of the cracks show up, and it's really a very, very pretty wood. And this kind of goes back now into the back of the house. And this just kind of shows you the doors are very similar to what you'd see in a Texas Hill Country house. They're all alder. They're really, really nice. Are they 6 panel? Yeah, 6 panel. So this is a guest bedroom off the front. I have a pantry in here that I can only reach to about this high, and it goes on about double my
You know,
height.
the builders say, we need to build it so needs to come out, here's all the counters, and I said, go on up. I said, there's real humans in here, I can get away with it. Or we can,
They'll get water.
you gotta give it
Sliding
a
one.
little sliding one.
You want to
Yeah.
Okay, this is our mudroom, so there's an outside door that comes in here, and this is the garage. And the laundry is behind, so there's a place to fold it and a place to put all your stuff. We had to put doors on everything because Schultz will take anything out and remove it. So the bottom was supposed to be open little cubbies. He just takes he's destroyed.
You like shoes.
He likes my shoes.
I don't think he likes your shoes, I think he just likes shoes you leave yours laying out and always put them out.
It's my house, I should be able to leave my shoes.
Is that the same turquoise that's in the dining room?
No, this is a sage green, it's more like what meadow green kind of color. So this is the door. This is the door the dogs will come into, and they have their own bathroom. This is the dog bathroom. So it'll have a kind of a half wall here, and it has a big shower head. So when Schultz go outside and he can dig down so much that he will get 1 inch to 1.5 inches plugs of mud between his pads, and they are horrific to get out.
The other day I walked in there and I said, come into this room, so he came in here and he sat in the shower and I said, that's just about right. He did not know what he was going to do, because I could get him in there with a half wall. I can stand in the doorway and get my shower thing, and there he's pinned. Because if you don't have the half wall, they'll go out and say, oh, you just leave it kind of open. I said, no. When they go in and the water goes, they're going to go out behind here and dodge out. So it'll be me and Schultz.
This is one of my favorite views. This is actually on the other side of the house now, back in the master bedroom, looking towards the front. But I love the arch and the ceiling height. It's pretty. This is Dr. Britton's room in Schultz, and I'm sure that's where they'll spend most of their time. This is his study.
And then we got everything adjustable heights, and they'll be drilling out some grommets in those countertops, because I've got lots of plugins up underneath stuff. I have like printer and computer stuff. It's all kind of hidden down a little hole.
There's this master bedroom, so we'll have a patio off the side, and the deck is above it, so it'll be covered. So that's our view of the back, and that's the color wall. It's a sienna, it kind of looks orange, but it's more of a terracotta type color. And this is one of my favorite pieces. It's a built-in in the master bath. This will all be mirror up here. And let's see.
And see, I will draw lines because
Yeah.
this is where I put my stuff. It should be organized and minimal. And this is where
So this is his side right here. This is my
And obviously that's about right, but I'll take a ruler and I'll just put it, just kind of move everything back in.
This
is, now upstairs, we have about half the house has an upstairs, so this is the football room.
Oh. Sorry.
My son keeps saying, when is the football room gonna be ready? I said, I'm ready to go in there, but we're debating. He wants me to get a projector.
I was gonna say,
He wants, I've looked at widescreen and projector. He wants that projector so you can actually tackle somebody on the wall. I mean, it's just a gigantic wall, so the projector would probably hang down from that midpoint between those windows. And we got all those seats across there. And then we will have our stadium chairs and all of our, I mean, it'll be pretty good.
And Travis, there'll be a big A over on this.
Yeah, I'll read it.
Y'all are coming in the back. That's just a soft, that's not beer. Yeah. I sat on the bench and then Schultz just hopped up here and I thought, well, this is gonna be interesting. Because he owns it.
This is my room. It's turquoise. And it's my craft room. So I'm up in the second floor in the trees. It's just a beautiful view. And so I'll have a center island, then I've got a place for my books, and then for all my crafts. Isn't that neat?
Tell them your life.
When does she like
Oh,
her?
nice chandelier. And this leads out to the deck. So if Dr. Britton is bad, you gotta get to go out. This is the Alabama bathroom on the second floor. Red. This is gray, and then you can see the black and white. And the flooring is that little bitty hexagonal black and white. It's really neat. There's one bedroom upstairs, so we asked our daughter-in-law, what color do you want it? We didn't ask Cameron. And so she wanted gray, so I thought it was a pretty color she turned around. This is the outside and the back. That's a covered patio. And then this is they call it the barn, the builder does. It's got a garage bay in it, but it's got a harvest kitchen in it. So we plan to have a lot of, we grew up on farms, so we're gonna raise our vegetables, and we got fruit trees, and we're planning to have bees, so place where I can process all that and not make a mess in the house is the reason I got it. I think that's it. Y'all are very nice to. That help, Kathy?
Yeah.
I'm sure she every time.
I'll be coming out there as soon as when it's open, you come out there, and I'm telling you, it is a cool place to be.
Next year.
We're ready for football room.
Yep.
Okay, thanks.
Okay, see
All right.
you later.
I know.
All right.
Wow. One day.
All right, so I understand you haven't had the ClinMed yet for inflammatory bowel disease. Okay. So I had ClinMed section in here, so I'm glad I left it here, so we'll go through that. So inflammatory bowel disease, usually two big diseases fall into this, Crohn's disease and ulcerative colitis. So you will see mild and moderate in practice. So we're going to focus just on the mild and moderate. I'm going to go over severe and fulminant treatment, but those would be more hospital-based. Those are very sick people. Usually they're going to have surgery consults and probably undergo some type of surgery. So tell me, what do you know about that? It tends to affect your age group. So usually the very young, teenage, 20-year-olds, and then as you get into the later part of life, you can see it in the 50, 60, and 70-year-olds. So what do you know about it? Anything?
Crohn's disease can be somewhat hard to diagnose and can take a while to get to that diagnosis, I think.
It can, if it's mild and ignored, I could see that, but usually they're going to do a colonoscopy, and so you can tell from that pretty quickly, and we'll go through that. So I can see where mild could be go undiagnosed for a while. What else?
Do they drop weight usually?
They can drop weight. So if a lot of the bowel is inflamed, they may not eat. And they'll learn to avoid food at certain times. They'll also learn to avoid certain foods. So they can be malnourished or undernourished. And they can drop 10 or 15 pounds in a short period of time. What else?
Maybe immunosuppressed in other ways.
So you can have other more autoimmune diseases. So it's a disease of inflammation. Autoimmune is a proposed reason for it to occur. What else?
My friend has it, and she said it's from her taking Accutane.
I don't know that correlation. Who did you say?
One of my friends.
We have one of the women in the first year has it also. Her mother has it. And so you will see it run in families also. Anything else?
My cousin had it.
Anything you want to tell us about
Yeah, I
that?
think his diet towards when he was starting to get severe malnourished, he was supposed to be eating all the fruits and like focusing on food groups, but he didn't really want to do that. So,
Yeah. Sometimes it's
it was hard.
it is hard,
It's
and
phenomenal.
there's a lot of food sometimes that they just have to avoid triggers, and sometimes it's just too many. Yeah.
My friend, before he realized that he had Crohn's disease, it got to the point where he had like ischemia. So they
Oh,
had to
really?
remove most of his colon.
Yeah, that can
And, like,
happen.
It was really ugly.
Yeah,
It's
small
taken
intestines mostly.
2 years for him to recover from losing all the weight and like
Wow.
many surgeries. And that's why I said the hard to diagnose. They couldn't figure his out.
Yeah, I would agree with some of that, you're
Yeah.
right. Because the colonoscopy won't get that part, you're right.
I had it and it interrupted work a lot, so I think I could see it being like a problem with daily activity and normal life if they always in the bathroom.
Mm-hmm. Sir Shirley King, anything else? Okay. Okay, so on the first page, it is one of the most common of the bowel diseases. It shows you there some of the different ethnic groups and who's affected most. I helped to write a chapter in the textbook for a Chinese book that was geared towards pharmacists, and I saw, and one of the chapters I wrote was on inflammatory bowel disease. In China, up until probably 30 to 50 years ago, almost unheard of. But as they have moved more into the larger cities and have abandoned more of a traditional Chinese, and have moved away from more agriculture to more Western type foods, the incidence has just mushroomed in China. So it's very much diet related, probably environmental related as well. So Asians can be affected as well, even though they are listed there as one of the more rare. Both genders affected, you tend to see more women than men with Crohn's and more men than women with UC, but can still affect both. There's your bimodal presentation in terms of young and the old. You can see prevalence-wise, your UC is the more common, so ulcerative colitis will be much more common than Crohn's. Crohn's can be more extensive, it affects more of the gut, it affects more of the gut wall, so they can tend to be more severe. So you may hear about them more often, but they are thankfully the lesser of the two. In terms of etiology, not really known, but there's all kinds of factors that are thought to contribute. You see infectious agents listed there, genetics, so tends to run in families, immunologic mediators, psychological, environmental, so many triggers that can play a part. I'm not going to really do much with this, the nicotine part, but I just want you to know that an unusual finding is that smoking seems to be protective of ulcerative colitis. It's about the only good thing I've ever read about smoking. But because of that, some people do use transdermal nicotine patches as an adjunct in treatment. But with Crohn's, you see a twofold increase in frequency. With the NSAIDs, you would think an anti-inflammatory would be helpful, but with multiple inflammatory type disease, especially in the gut, and with colon cancer, you can see an increase with the use of NSAIDs, except for aspirin. Aspirin users tend to have lower incidence of colon cancer than those who never used. Okay, pathophys. Questions or comments on that? Okay, let's look at the pathophys. So here in these two diseases, it is felt to be an imbalance between pro-inflammatory processes in the body and anti-inflammatory processes. So it's thought that the pro-inflammatory way outweigh and have become out of balance with the anti-inflammatory processes or regulatory systems within the gut. So treatment is aimed at inflammation. Here are the differences in the two. So they both affect the gut, but they differ in their presentation, they differ in their constitutional symptoms and in their complications. So just kind of going down through here, usually, now the sicker patients with UC can certainly have symptoms, but you'll see that more typical in presentation from constitutional malaise, fever, abdominal pain, weight loss will be more common with Crohn's. Here is, the distribution here is one of the ways that they will help to diagnose. So when they look at the gut by colonoscopy, the distribution in UC is continuous. Usually involves mostly the rectum or the sigmoid colon, and then it can have distal effects as well. But the colon is continuously affected. Whereas in Crohn's disease, you will have segments of normal gut with segments of abnormal or diseased gut. A common problem that also occurs in Crohn's is they get mouth ulcers. And that's one of the common complications that you would have to treat. Rectal involvement is almost always in ulcerative colitis. It would be rare to have to just have distal disease without also proctitis or sigmoiditis. Strictures, common in fistulas with Crohn's. With UC, it's usually just the submucosal, or the mucosal region. With Crohn's, it is the entire gut wall. Crypt abscesses more common with UC, and then the cobblestone appearance with Crohn's. So with ulcerative colitis, here is the most common is proctitis or the involvement also of the sigmoid. This is referred to as left-sided or distal disease, and then this is referred to as pancolitis or throughout the whole colon. The small intestines is not affected in UC. This is going to be really important when we pick a drug. So we use a lot of topicals. So topicals, we think of skin, but here topical is that wherever we put the drug, we're affecting local changes. So different dosage forms will have different abilities to get to these more distant regions in the colon. So this part is important. Look on the top of page 4. The mucosal damage that you get with in ulcerative colitis leads to the diarrhea and the bleeding. So you will see that as a complaint in both of these diseases. So that's usually sometimes what will drive people to go see the doctor, because rectal bleeding is scary for folks. There are extra intestinal effects. I'm not going to cover those when prepared to, so I'll leave it to the person who comes and talks to you next week. For Crohn's disease, it's usually this area is the most common. So an ileitis along with juxtaposed right colon area, these are the most common areas. But with Crohn's, it can occur anywhere from the mouth to their anus. So you can see colon involvement, it's not as very common, meaning up in here. You can see colon alone, much less common. So much more invasive disease and has more significant side effects and complications as well. I think we hit all the others. Okay, let's look at classification of severity. So the classification of severity rely on some older guidelines. And they're mostly looking at symptoms. But there are some new guidelines coming along, and I told y'all to keep a watch out for the classifications that will rely more on the disease of the patient, which the ones currently do. More being able to quantify the inflammatory burden. So looking at more inflammatory markers. And then the other is disease course, which you really don't get in the current ones. So different ones will come down the road. The ones that they use right now for ulcerative colitis are the ones that I have on this page. I have taken that upper or middle section and just put it in a table, so they're redundant material, just whichever way you want to look at it. So it looks at severity, is how they stage it, and it's based on stools per day, blood in the stool, systemic complications, SED rate, and then toxic or life-threatening complications. So these you see are more, are based on what the patient reports. The systemic complications could also be what the patient reports, but may also be what you as a clinician look at. So you get your input and then a SED rate which you would do. So these staging are going to be a combination of patient subjective reporting or history and then what you can measure. So mild would be the fewest stools per day. They may or may not have blood in the stool. They usually have no other systemic manifestations, and their SED rate would be normal. Moderate would be more than 4 but less than 6, so 5 or 6 a day. Blood probably would be in the stool. They may have minor complaints, and their SED rate again would be normal. The more severe and fulminant, here you're getting to 6 to 10 stools a day. Blood, yes. Cramping, yes. With the fulminant, which we're usually going to hospitalize those folks, they may require transfusions because they've lost enough blood. The systemic complications would be fever, tachycardia, symptoms related to infection, abdominal pain, tenderness, distension. Has Dr. McNeil done his abdominal? Okay, so you would be familiar with those manifestations. And elevated SED rates with those severities, and then the fulminant are at risk for toxic megacolon and bowel perforation. Often that will lead to a colectomy. When patients with UC have colectomy, it's curative. They don't have a colon anymore, but they don't have UC anymore. It's gone. Okay. On the next page, page 6, for Crohn's disease, they use a scoring system called the Crohn's Disease Activity Index. If you look at the very last page, I pulled it off and gave you the calculator. So this is online. You can go on, have patients fill it out. So again, some of it is based on what the patient reports to you, and some it's based on what you note. If you look down through just the main headings, it's the stool pattern, so number of stools. Are they having to use an antidiarrheal like Lomotil? How much, and then having them rate their pain. So again, a subjective rating. General well-being each day over the last 7 days. What are the complications? Those would be things you would add in. And then a finding of an abdominal mass. If you look down through there, the things that carry the most weight, which add to the staging, are the patient's reports. Their abdominal pain, if you look down through there, 35, 70, 105 points. To be mild, you just have to be a 150 or above score. So you can see that if they've got moderate to severe pain, that can already put them very close to the mild. General well-being, again, you see poor 98, very poor 147, terrible 196. So how the patient feels and what they're reporting to you in terms of symptoms carry great weight in terms of staging according to current staging guidelines. Okay, so looking down through there, you're looking at the score on that CDAI. then how can they tolerate diet? Can they eat most anything they want, or are they avoiding lots of foods? Are there any constitutional symptoms? So are they complaining of nausea, vomiting, fever, abdominal, what kind of abdominal symptoms they have, and then their weight. So Travis brought up the loss of weight. So usually you won't see weight loss until you get to the more severe stages. Okay, questions about those? All right, so let's look at goals of treatment. So think about this in terms of other inflammatory diseases we've talked about. So what kind of diseases have we, over the year, talked about that where inflammation was the major thing we were treating in order to control the disease?
Gout?
Pardon?
Gout?
Gout, okay. In pulmonary, lung-wise, what do we talk about?
Asthma.
Asthma, okay? So the whole thing with asthma is control the inflammation, control the symptoms, right? What do we talk about in musculoskeletal besides gout?
Arthritis.
Rheumatoid arthritis, okay? So keep those in mind because it's very similar. The drugs we're going to use are very similar. You're going to see the same ones popping up again. So we want to relieve the inflammatory process because that is what's destroying their gut. It's what's making them sick. It's what's making them intolerant of diet and blood loss. It's also, think about inflammation is body-wide. So the other problems that they have, the other organs that are affected are usually due to that inflammatory process going on outside of the gut. So we want to prevent, or if whatever complications they have, we want to prevent them, slow them down, or stop them in process. The other thing, remember in rheumatoid arthritis, our first goal was induce remission, right? Calm it down, get the inflammatory process to stop. Then the next step we took is we wanted to maintain that. Same thing here. So it's nothing new. It should be familiar territory you're starting to walk in, even though you don't recognize it all at once. As you get into it, your brain will go, oh yeah, I've been here before, okay? So let it do that. So even though the drugs, you're going, what are those drugs? I'm telling you, the more your brain will do it, the more the brain will start to pay attention and go, oh, they're serious about this. I'm going to start learning it, or paying attention, or recalling it, or bringing it back together. So let those things help you with this disease in particular. Surgical palliation or cure, so you see surgery is a cure. We don't put everybody through surgery, but if you get toxicity, toxic megacolon, that is the treatment. If you've had UC a long period of time, if you have precancerous changes, these folks are very high risk for colon cancer. So colon or cancer prevention can be done through surgery. And then improve their quality of life. You can imagine that this has a huge effect on their quality of life and how they plan, what they eat, what they do, when they do it, where's the bathroom, how close am I to it, and how much time I spend in it. Okay. So management. So one of the non-drug things would be look at their nutrition. So how could you tell if they're malnourished or not? What would you look at?
Albumin.
Albumin. So that would be one thing that would tell us about protein. Anything else we could do?
BMI.
Pardon?
I said
BMI? What else? Skin, so you could look at skin, you could do, a dietitian would do calipers to measure their body fat. Having them see a dietitian for an evaluation. They could tell you a lot of where deficiencies could be. Is there anything you can measure? Other things? Pardon?
Turgor.
Say it again. Just louder, I just can't.
Like skin turgor.
Skin turgor, thank you. Okay, that would tell us more about dehydration. What else? Pardon? Okay, so you can measure vitamin levels, some, right? B12, vitamin D. Anything else come to mind? Okay, so there could be a whole panel of things that you could look at folate levels to start to tell it how they're doing. The other thing, and when the dietitian comes to talk to you during the nutrition module, one of the things she will tell you is that the gut really needs to have food in order to function. It's its job. If you deprive the gut, then the gut doesn't do very well. It will change. It may atrophy. Your ability to absorb may change. So we want the gut to continue to do its work in order to stay healthy. Lauren, okay, so I'm still on target. So it's important that we don't put them in PO, we don't put them to bowel rest unless they are so symptomatic that we want to just stop stooling for a while just to give them rest. But we want the gut to stay active, and we want to give it the nutrients also to keep it as healthy as possible. And then we want the gut to also be able to do its job so that the person can stay healthy and absorb nutrients. Okay. So, but also looking at eliminating foods that are triggers. So if they're lactose intolerant, getting rid of those types of foods could be helpful. Maybe a gluten-free diet would help. There's no rhyme or reason right here. They'll often look at lactose to try because it's a common irritant in our society. So looking at, like, I've put some other insoluble fiber, so fiber intake, we may have to adjust. Non-absorbed carbohydrates, because that will increase their diarrhea. And then at last, the last choice would be to put them on enteral parenteral. Enteral would always trump a parenteral because enterals have short-chain fatty acids that are needed for gut health. Parenteral put the gut at rest, and so there's a lot of problems if we do that for long term. But we can, if we need to, we can feed them IV for a period of time until they can recover. Surgery on the next page. Again, what I want you to know is surgery cures UC. It does not cure Crohn's, but it can be used to ameliorate symptoms. Or if, who told us about getting, no one, a gangrenous gut, ischemic gut changes. Okay, questions about that? Okay, so that's the quick. I am not going to test you over any of that, but it may be things that you need to remember in order to choose your therapy. In terms of overall drugs, so drugs are going to control disease process, they are not going to cure it. So it's just like asthma, just like rheumatoid arthritis. Can't cure it, but you can control it. So the drugs that we're going to use, our mainstays are these 5-aminosalicylic acid derivatives, 5-ASA derivatives is usually the way they are referred to. And corticosteroids, those are your foundation drugs. For advanced disease, or disease that will not respond to these two, even if it is a very localized or limited disease, then we go to immunosuppressants. We may use antibiotics. You'll see that in very sick people, we'll do that. We can use the biologics. The TNF alphas are mostly used there, so like Humira, Remicade, Cimzia. Those three have all been used in UC and CD. There is another group called the anti-integrin antibodies. Those are only for Crohn's disease. I'm mostly just going to mention them so that you'll know that they're advanced, but they are very expensive and used only in severe disease. So when you choose a drug, it will depend on, is it Crohn's, is it UC? How extensive is the disease? For ulcerative colitis, that makes a big difference in terms of what you choose. And then the formulation. So here, dosage forms, whether it's suppositories, enema, oral agent, a foam, all of those will be considered based on what is going on in the gut. We will use some drugs to induce remission, and then we'll use other drugs to maintain remission. So kind of categorize them that way. Induction, maintenance. All right. And then there's several adjunct therapies. I didn't list them all here, but I have it in other sections in the handout. So what I'm going to do next is I'm going to go through the drugs, and then we'll come back and talk about how to apply them to first also ulcerative colitis, mostly mild and moderate, and then we'll talk about Crohn's disease. So the new group of drugs to you is this first set, this 5 aminosalicylic acid derivatives. The old one in this group is sulfasalazine. You saw it when we talked about rheumatoid arthritis, but we didn't focus very much on it. It's not a very powerful drug in that disease, and it has some side effects. So we tend to use methotrexate, if you remember, as one of our first ones. When we talked about triple drug therapy, remember for mild RA? I've gotten blank stares. Okay, remember we talked about first drug we use when we are trying to treat RA, we use steroids and nonsteroidals, right, to get the inflammation down. Remember then when we're trying to keep them if we induce remission, then we keep them out of remission, or keep them in remission. Talked about methotrexate, right? Then we talked about if that didn't work, and those are non-biologic, that's a non-biologic. So then next if it's still mild and we've got early disease, then we would go with other non-biologics, remember, as we're coming back? Okay, so sulfasalazine was one of those triple drugs that we could use orally to treat RA. So it has anti-inflammatory properties. It gets metabolized, so sulfasalazine is not the main product, it's just the drug that gets it into the system. It cleaves into 2 different products, and one of them is that first one, that's sulfapyridine. It's a sulfonamide antibiotic. Where have you heard before that antibiotics have anti-inflammatory activity?
Derm.
Talked about dermatology, right? Which one in particular? You talk about the tetracyclines a lot. Like with acne, we use it that way. Okay. Rosacea, remember? Okay. Same thing here. The other drug that it gets cleaved into is mesalamine, and mesalamine is really the active ingredient here. The reason sulfasalazine is still around is that it is cheap, dirt cheap. Whereas all the other products that contain mesalamine, the active agent, the more effective, is that they're very expensive. Okay. So that's why it has stayed around. So the one thing to remember with sulfasalazine is that it gets broken down into a sulfonamide antibiotic. So people who have sulfa allergies that are usually more severe, you want to avoid it. See, it's easy. All this stuff you just have to bring forward and repeat. And if you do it here, you'll remember it in other things. So I'm doing you a favor by going over the treatment of the drug. Let's see. The other downside with sulfasalazine is that it's only oral. So what they've done with the mesalamine products is they have developed a lot of topical products to put the drug right where the problem is. So as you go down through there, you see there are topicals in terms of suppositories, enemas, or foams. Okay. And that's on the next page, sorry. So oral agents we're going to use for extensive disease. So oral agents can get any part of the gut. We're not limited. Suppositories can only, and I've got this in another place in the handout, but suppositories can only get the first couple of inches of the rectum. So 5 to 8 centimeters is what you will see. If we use a foam, then we can get on up into this lower part of the left side of the gut. We can use an enema, which can get us as high as the splenic flexure. That's as high as we can get with any topical therapy. So if you have left-sided disease, sigmoid involvement, and rectal involvement, you can hit it with these topicals. The good thing about topicals is that they tend to have less side effects, and you don't have to dose them as often. It then comes down to is people's adherence to that, because we may ask them to do suppositories a couple times a day, enemas a couple of times a day. Well, people usually don't want to stick things up their butt several times a day, but they're very effective. So you just have to balance what are people willing to do on a regular basis that will affect the change needed. Okay. With mesalamine, the other advantage to it is that it's not a sulfa-containing antibiotic, so you can use it in people that have sulfa allergies. The drug interaction, the main one to keep in mind, at least if you're using an oral, is not to take it with an acid-suppressing drug. So stay away from the antacids, the proton pump inhibitors, and the H2 antagonist. There's two newer ones on the market, that osalazine and valsalazine. These are very new. They are more long-acting, they more target and don't really dissolve or deliver the drug until they get pretty far down into the gut. So you can imagine they're a lot more expensive products. If you look at the next page, page 9, here are the products. The ones in yellow are the ones that I want you to learn as examples. So with sulfasalazine, I want you to know the brand name asulfidine. With the oral mesalamine, I want you to be familiar with Pentasa. You will see that both in UC and CD. So if you look at that column for indication, it shows you which ones are used in ulcerative colitis and which ones are used in Crohn's disease. For the most part, they all carry a ulcerative colitis. We don't use topicals with Crohn's, so the topicals are just going to be for the ulcerative colitis. You will also see under formulation the many descriptors. So these drugs are all going to be formulated in a way that keep them from dissolving until they get to the gut. That's huge. We've got a couple of new steroids I'm going to introduce you to that don't dissolve until they get down to the ileus, the ileum or the colon. So that's huge because then we don't have all the systemic absorption and the effects, and so we can use them for longer periods of time with less effect on or side effects on the patient. The mesalamine topicals, you have suppositories and retention enemas. If you look over on the side, the suppositories are reserved for proctitis. Remember, because that's as far as they can exert an effect. The retention enemas, these will reach up to that splenic flexure, so they'll cover the left side of the colon. And they are usually given at bedtime. The longer they can be retained, the more effective they are. So if a patient can retain them for up to 8 hours, they get really good effect. Now, for somebody who's got a really irritable gut, that is going to be hard. So it will take time for them to develop that tolerance of a drug being placed in the lower colon. If you look under the Roesa or the retention enema, you can see where it can stain clothing, so you would have them wear a pad or keep making sure they're warned about the possibility of the drug ruining their night clothes. You'll see most of them have moved towards once or daily formulations. There are some that require more often, so you know that the more often you're asking them to do it, the more often they will miss. The sicker people are usually, they'll do well, and when you're trying to induce a remission, it's the maintenance phase, long term, where you'll see less adherence. If you look on the next page, page 10, that little table at the top is really important. So that's your reminder, and you've got this picture right beside. Again, suppositories, only the rectum. Foams, sigmoid colon. Enemas, all the way up to splenic lecture, orals, the whole thing. Okay? So I said it 3 times, really important. The bottom of that page 10, it's just the same information, it's just another way to look at it or to organize it. Whatever speaks to you the most is fine with me. If you look at the next page, I really like this chart. I like the visual that it gives you. So what they're showing you at the top is these are all the brand names of the different 5-ASA products, right in here. Okay. On the left-hand side down, what would be more the y-axis is you have the gut from the duodenum down to the rectum. And then what they're showing you in color is what part of the gut those drugs will affect. Then you have Roesa and Canesa, which are the enema and the suppository. And so they're showing you oral administration, rectal administration. So it gives you a nice visual about what part of the gut those drugs are going to affect. So match them up with the patients where the disease is. Question? And then there's just some pictures there for you to reinforce or give you some images to lock onto as you're learning the material. Okay, let's take a break. We'll come back just right after Q&A.